and welcome to The Explainer. Today we're taking the incredibly complex molecular biology of precision oncology and translating it into high-yield, board-ready clinical pearls. We're looking squarely at the absolute revolution changing the face of targeted cancer therapy, BiTEs and ADCs. Look, if you're managing hematology or oncology patients right now, understanding these agents isn't just optional anymore. It is a strict requirement for managing your patients on the wards and, of course, for acing those exams. Let's get into it. Here's our clinical roadmap for today. First, the Relapsed Leukemia Challenge. 2. BiTEs, the immune synapse. 3. ADCs, the Trojan horse. 4. Navigating clinical therapy toxicities. And finally, we'll wrap up with a high-yield board review.
All right, starting with Section 1, the Relapsed Leukemia Challenge. Let's anchor all of this basic science into a real-world clinical vignette to see exactly why we even need these therapies. So, meet our patient, Rohan. He's a 29-year-old guy who is unfortunately facing his third relapse of B-cell acute lymphoblastic leukemia. His bone marrow biopsies is showing an overwhelming 72% blast count. Now look closely at his failure matrix. Traditional salvage chemotherapy has totally failed him. Why? Well, it's a mix of multi-drug resistance driven by MDR1 overexpression, clonal evolution, T-cell exhaustion, and a bone marrow sanctuary that's just preventing adequate drug penetration. For a patient like Rohan, who has an ECOG performance status of 2 and isn't eligible for an immediate allogeneic stem cell transplant, traditional medicine has basically run out of answers. He is the absolute prime candidate for targeted precision agents. Now, what's really fascinating here is how perfectly the agent Blinatumomab fits Rohan's exact clinical profile. Looking at the checklist on the screen, Rohan is CD19 positive, which gives us the perfect available anchor for the drug. And hey, even if his endogenous T-cells are exhausted, this therapy can forcefully redirect them. Plus, he's Philadelphia chromosome negative, meaning we don't even have to worry about compounding tyrosine kinase inhibitor resistance. We are essentially bypassing standard chemoresistance mechanisms altogether. Moving right along to Section 2, BiTEs and the immune synapse. Let's unpack the actual molecular mechanism of these drugs. Medicos, listen up. This is a heavily testable concept for understanding both how well these drugs work and the adverse events they cause. High-yield pearl here. You absolutely must know these steps in order. It starts with dual binding, which leads to T-cell activation. But here's the kicker. This activation happens completely independent of major histocompatibility complex, or MHC, presentation. That directly triggers targeted cytosis, ultimately giving us our clinical response, which, incredibly, is often deep minimal residual disease negativity. This diagram brilliantly illustrates the serial killing effect at the cellular level. The BiTE simultaneously binds CD3 on the T-cell and CD19 on the malignant B-cell. It basically forces the T-cell to engage, dump lethal perforins and granzymes to trigger apoptosis, and then quickly disengage so it can move right along to the next malignant blast. And notice the structural detail here. A BiTE is a tiny, roughly 55 kilodalton molecule with absolutely no Fc region. Because of that, it has an incredibly short half-life of only about 2 hours. Clinically, what does that mean? It means it absolutely requires a continuous IV pump to maintain therapeutic levels. All right, Section 3, ADCs. Think of these as the targeted Trojan horse. Literally, think of ADCs as a molecular Trojan horse. Note the critical structural components we designed for this targeted delivery. You've got a highly specific monoclonal antibody, an attached linker, and a fiercely potent cytotoxic payload. These linkers can be either cleavable or non-cleavable. Pharmacologically, we're aiming for a very specific drug-antibody ratio, or DAR, of 4 to 8. That sweet spot ensures optimal stability while it's in transit through the bloodstream. And that payload? We're talking about classes of drugs like maytansinoids and auristatins that are literally 100 to 1,000 times more potent than standard systemic chemo. There is no way you could give these safely without that targeted antibody. So let's map out the pharmacokinetic pathway of this Trojan horse. First up, the antibody binds the antigen on the surface of the cancer cell. Second, the whole complex is internalized via endocytosis. Third, and pay attention because this is a critical board-relevant step, is the intracellular lysosomal cleavage of the linker. Finally, that massive cytotoxic payload is dropped directly onto the DNA, executing the kill. Seeing it mapped out visually like this really cements the concept beautifully. The ADC binds, the membrane invaginates, and it travels right into the endosome. Once it merges with the highly acidic lysosome, the sudden pH shift and the proteases completely cleave that linker. The payload is unleashed inside the cell, shattering the DNA. But notice this super important detail.
Some of this payload is actually membrane permeable. It can diffuse outward to execute a collateral bystander effect, killing neighboring cancer cells that might not even express the target antigen. How cool is that? So bringing our two agents into a head-to-head clinical perspective, we can contrast the continuous 28-day pump infusion required for the BiTE, Blinatumomab, against the intermittent bolus IV dosing of the ADC, Inotuzumab Ozogamicin. Now, while both of these are incredibly effective bridges to a stem cell transplant, routinely reaching over 70% MRD negativity, their very distinct mechanisms dictate vastly different toxicity profiles. Which leads us perfectly into Section 4, Navigating Critical Therapy Toxicities. Look, knowing exactly how these drugs work at the molecular level tells you exactly how they're going to cause harm to your patients. We really need to juxtapose these adverse events conceptually. BiTEs trigger a massive, systemic, immune-mediated storm simply because you are forcefully activating the body's entire T-cell repertoire. ADCs, on the other hand, result in highly specific, payload-driven organ damage, usually due to where the drug is processed or where off-target binding occurs. For BiTEs, your classic board presentations are going to be cytokine release syndrome and ICANS. CRS presents with fever and hypotension, and it's driven by massive IL-6 release. Your instant management reflex here should be tocilizumab, which is an IL-6 receptor blocker. But you've got to watch out for ICANS. This is severe neurotoxicity presenting as confusion, aphasia, or even seizures. Toci won't cross the blood-brain barrier effectively enough for this, so ICANS is managed distinctly with dexamethasone. Oh, and be hypervigilant for tumor lysis syndrome at the very start of therapy, right when the patient's blast burden is at its absolute peak. Conversely, when you're managing ADCs, you are specifically looking for payload collateral damage. A critical clinical warning for the ADC inotuzumab is hepatic veno-occlusive disease, or VOD. That risk absolutely skyrockets if the drug is given within 2 months prior to a stem cell transplant. For other ADCs like TDXD, a classic hallmark is interstitial lung disease. If you see that, it requires immediate cessation and hydrosteroids. And for MMAE-based ADCs, peripheral neuropathy is going to be your dose-limiting cumulative toxicity. All right, let's wrap this up with Section 5, High-Yield Board Review. It's time to test your retention with a classic clinical scenario. This is exactly how you'll be tested on the wards and on your exams. Go ahead and pause the explainer right now to lock in an answer. You have a 34-year-old relapsed patient with CD19-positive B-ALL, exhibiting new-onset, grade-3 confusion and aphasia on day 10 of an unspecified precision therapy. Which of these combinations fits? Okay, the correct selection is B, Blinatumomab causing ICANS. This perfectly illustrates the criteria for neurotoxicity. Notice the patient has confusion and aphasia, which are central nervous system symptoms, rather than the systemic fever and hypotension we'd see in cytokine release syndrome. And because he is on a novel agent for CD19-positive B-ALL, Blinatumomab has to be the culprit. Let's rapidly lock in our final high-yield pearls to synthesize all the structural and clinical differences we've broken down today. Remember, BiTEs need dual binding. Blinatumomab requires a continuous pump because of that tiny half-life. ADCs completely rely on acidic lysosomal cleavage to drop their payload. And please never confuse your rescue meds. Tocilizumab puts out the systemic fire of CRS, while dexamethasone puts out the neurological fire of ICANS. Seriously, take a mental screenshot of this slide right now. Ingrain these structural definitions, like the ADC-DAR ratio of 4 to 8, and perfectly memorize those distinct rescue pathways and red flag toxicities for managing your patients on the ward. Knowing that inotuzumab causes fatal VOD post-transplant isn't just a fun fact, it will literally save your patient's life. Both BiTEs and ADCs are fundamentally redefining the landscape of oncology right now, delivering unbelievable response rates in leukemias that used to be considered terminal. But as we look to the future and expand these targets way beyond hematology into solid tumors like breast and urothelial cancers, I'll leave you with this question. Which mechanism, redirecting the body's own systemic immunity via a BiTE, or deploying a targeted hyperpotent Trojan horse via an ADC, do you think will ultimately crack the code for eradicating solid tumors? Think about it. Thanks for joining me on The Explainer today, and keep mastering the medicine.